Hi, everyone. Welcome to Echo HIV, Finding the Invisible Patient. I'm your facilitator, Rachel Deer with DKB Med. I'm joined by my colleague, Amy, and I've got my colleague, Justice, here as well, who will be tuning in. Thank you so much for joining us, and thank you for turning your cameras on. We would like this to be as interactive as possible, so it's always great to see all of you. Welcome to our first module. It's one of 5, so we'll be meeting for the next few weeks. We do have some slides to help us get started. I know some of us are unfamiliar with the ECHO model, so I'm pleased to go through that with you. And then we'll do some introductions. And I've got my wonderful Dr. Jean Anderson, one of our hub faculty members, and a couple others will join shortly. And then we'll go through our first module. So why don't we get started? All right. So if you're here, you obviously have the required technology, but just a reminder. So all you'll need is access to Zoom. You can use your computer, your tablet, or your phone. Just note that some capabilities may be limited on phones and tablets, like the chat feature or any of the other features. So we want to test it out. If you wouldn't mind opening the chat, just enter what type of machine you're using, computer, tablet, phone. Just want to make sure that everyone's comfortable using the chat. If you have any connection issues or any issues with anything related to Echo, feel free to reach out to us. Again, my name is Rachel, and I've got my colleague here, Amy, who will join us every week. And then you'll see a couple other names, Tabitha and Faith, who might join us for other sessions. We've got our email and phone number as well. And I see that a few people are on the computer and cell phone. Good to know. So for those of you that are not familiar with Project Echo, Echo was developed by Dr. Sanjeev Arora, a liver disease specialist at the University of New Mexico Health Sciences Center in Albuquerque. He was frustrated that he could only serve a fraction of the hepatitis C patients in the state, so he created this free educational model and mentored community providers across New Mexico in how to treat the condition. So the model is not traditional telemedicine where the specialist assumes care of the patient, but is instead telementoring, which is more of a guided practice model where the participating clinician retains responsibility for managing the patient. Echo really is all teach, all learn. So as I mentioned at the very beginning, we want this to be as interactive as possible. Thank you so much for having your cameras on. And we're going to be talking about co-management of cases. There will be peer-to-peer learning. We want to learn from all of you. Dr. Anderson is here with great insights, but she can learn from you as well. And then collaborative problem solving. We talk about our patient cases. So Project Echo links expert specialists at an academic hub with primary care clinicians in local communities. I understand not all of you are primary care clinicians. So when we do introductions, we'd love to see what your specialty is. And it links them with, so you all are the spokes. The program outline this week's going to be just a little bit different because we have our introduction. So, but typically it's a 10 to 15-minute lecture at the start of each session. And then we move on to the Q&A. So we want to hear from you if you have any questions. And then we go to the case presentation. And I'll talk about that in a moment. Just the modules on what you can expect. So this week is what is SAVA and why is it important? Then we talk about substance abuse, depression, intimate partner violence, systems level challenges and models of care, special populations, interventions, and resources. So that case presentation, we do have a form on our website that's available, but if any of you at the end or the middle of the presentation realize you would like to volunteer to present a case, we would love that. We always have some cases that our hub team presents, but we definitely want to hear about your patients. So we could also email that to you as well. So you, the spokes, would present your case, include any lingering questions about managing your patient, And just note that your case does not need to align with the lecture content or the learning objectives for that specific week. And then there are hub teams. So Dr. Anderson, and Allison and Lauren, they'll summarize the case, ask any clarifying questions, ask for recommendations from the rest of you. They'll make their recommendations and summarize what those recommendations are. And I know we've got some folks trickling in, so welcome again. Thank you so much for joining us. We're just getting started. So a little meet and greet, but before we do that, I have some polling questions. Just want to make sure everyone's familiar with the Zoom polls. So why don't we do that before we all introduce ourselves? So, and again, if you're on a phone or a tablet, you might have to scroll a little bit. So the first question is, have you ever participated in an ECHO program before? Yes or no? 2, are you currently seeing patients? Yes or no? And here's a fun one. What is your favorite fall activity? Sweater weather, pumpkin picking, football, or a basic pumpkin spice latte, or any warm drink? I'll give everyone a moment to answer that. And then as you're answering, I'll just call on everyone as I kind of see you appear in Zoom, and I'll ask you these questions that you see here on the screen. So everyone is ready for that. All right, we've got a little more than half of you responded, so just give everyone another few moments. And we understand that some of you are with patients, or well, I doubt you're in with patients doing this, but you're in clinic or you're at the office, so you're unable to turn your camera on, or maybe you don't have a camera, and that's totally fine. Definitely just put any questions or any comments in the chat and we'll read those aloud. But it's always nice to see your faces. All right, so let's see. Most of you have not participated in ECHO before, so welcome to your first ECHO. Most of you are seeing patients, 63%, and we're kind of split here, a little cooler weather and football. Very nice. Okay. All right. So now that we can see everyone, and hi, Allison, and hi, Lauren. Thank you both so much for being here. Why don't I have the three of you introduce yourselves before I go around to the rest of the group? Dr. Anderson?
Good morning, everybody, and welcome. I'm Jean Anderson. I'm a professor emerita of gynecology and obstetrics and medicine at Johns Hopkins, and directed the Hopkins HIV Women's Health Program for about 34 years.
Thanks, Jean. Allison?
Hi, everybody. I'm Allison Livingston. I'm a nurse with the Johns Hopkins HIV Women's Health Program. I work with women living with HIV who are pregnant and also who are seen in our GYN clinic. And we also have an outreach program where we work with the prison system with patients, clients that are being released. So glad everybody's here. Thanks.
Thanks, Allison. And Lauren?
Hi, good afternoon. My name is Lauren Rainier, and I'm a social worker based out of Pennsylvania. And my background is working with individuals who have HIV, other infectious diseases, as well as working with sexually transmitted diseases and a PrEP clinic. Happy to be here.
Thanks, Lauren. Okay, and I'll just go around very quickly. I'll just call out names that kind of appear. And again, if you are so don't forget to unmute yourself. If you are unable to do that, put it in the chat and we'll read those aloud. So I'll just start. Paul, nice to see you. Paul, what do you do and where are you practicing?
I'm like 95% retired OBGYN in Sarasota, Florida. Trained at University of Florida and New Jersey Medical School in New York.
All right. Thanks, Paul. And Hannah, nice to see you.
Good to be here. Hannah Kuru. I work for Family and Medical Counseling Services in Washington, D.C. And I am a substance use counselor. Actually, I'm a social worker in substance use. And in the past, I had some ladies, well, some clients who were living with HIV. And I was interested in the topic, and that's the reason why I applied to participate in whatever is going on. I haven't had any female clients being pregnant and living with HIV, being pregnant and all the rest, but I'm aware of the fact that a number of them do have mental health issues, depression in particular. I'm not too sure of the inter-partner poor relationships and, well, domestic violence and the rest, but I'm interested in seeing what is going on in that area. For now, I'm dealing mainly with substance use. Treatment, not prevention. Treatment is what I'm working on. So I'm coming in from the substance use perspective.
Great. Thank you, Hannah. Thanks for being here. T. Nolan, you're on camera. I'm just not sure your first name.
My name is Tim Nolan,
Okay,
and
Tim.
I'm a nurse practitioner doing HIV care in Ryan White clinics for many years in North Carolina.
All right. Thanks, Tim. And just a heads up, I know some people join on their phone or someone else's machine. So Amy, my colleague, might be reaching out to you in the chat just so she can update your name and make sure she checks you as attended. Michelle.
Hello, how are you?
Good. How are you doing? And where are you, Michelle?
Psychiatric Institute of Washington, and Hannah is laughing because we just stopped working together recently. So I work in the detox unit here at PIW. We do have patients that come through that are HIV positive. Before I left Family Medical, I was also working with the Ryan White clients. So I'm here.
All right. Thanks for joining us. We appreciate it. Mashida in the chat, pharmacist specializing in HIV and working with AIDS Healthcare Foundation Pharmacy in Los Angeles. I'm at work and can't talk. Completely understand. Elmer, you're on camera, so I'll call you out to introduce yourself.
Hi, good afternoon, everyone. My name is Elmer Amparo. I'm an internal medicine nurse practitioner here at Washington, D.C. area. I have experience with the ECO when I was in the Indian Health Service for the HIV. So that's why I'm interested to join this, because this is a collaborative effort with the team and present your case and makes you comfortable in managing the HIV patients, which I have a few of my patients which is diagnosed with HIV, and I have with its hepatitis C also. That's why it's nice to combine those together. All right, thank you, and nice meeting you all. I'm looking forward for this.
Okay, great. We're looking forward to it as well. All right, and Quinteith, which is Team Jones, a psychiatric nurse practitioner who is actively working at a behavioral health transition clinic in Texas in the office. No worries there. Any other folks that would like to introduce themselves and turn their camera on, that would be great. If not, just in the interest of time, I will ask you just to put it in the chat so we can get started on our first presentation. But just a shout out, thank you so much for joining. Sherry, Patricia, Jacqueline, Courtney, Kathleen, Kanash, Christos, Barbara, Alonda, Jenny's joining. Fitzy, it's so great to have all of you, and we really hope we see all of you in the coming weeks. And Courtney, a new grad PA in primary care. Nice to have you. Okay, before we do our first presentation by Dr. Anderson, I just have a few questions to ask you because you will see these at the end. All right, and we do ask during the presentation, just keep yourselves muted. When we're done and we're at the Q&A part, definitely come off mute if you have any questions. So the first one is approximately what percentage of women with HIV have experienced intimate partner violence? 10, 30, 50, or 80%? And the other question is injection drug use accounts for the highest proportion of HIV transmission among women from which group? Black, Hispanic, Latina, white, or all races and ethnicities are equal. So just pay close attention because you will hear those answers in the presentation, and we all want to get 100%. And we've got another group going Tuesdays at 8 a.m. Eastern. So they did well, but I think we could have a little friendly competition. I could report back to them how well all of you did. And Barbara said in the chat, HIV prevention program manager with Northwell Health in New York. I'm in New York, so very familiar with Northwell. It's nice to have you with us. Okay, I'll just give everyone another moment. And again, the rest of our sessions will really start with our presentation. We just need a little more time for the first one so we can go through what ECHO is. For those that might have missed, we had a little presentation on what an ECHO is. If any of you would like a copy of that, put that request in the chat and we can share that with you. Okay, so we will not look at the answers just yet. All right, so let's go to our presentation by Dr. Anderson. And before that, Patricia, PA in Florida. I was a GI PA in Davie, Hollywood for 10 years before going on disability, looking to return to the workforce and catching up on a lot of topics. All right. All right. And Amy will make note of anyone who would like a copy of those intro slides. No problem. All right, so let's get started.
Hi, I'm Jean Anderson. I'm a professor of OBGYN at Johns Hopkins University, and we're going to start with Module 1 for the ECHO HIV project. The learning objective for this module is to describe the prevalence of and effect of substance use disorders, depression, and violence on the course of HIV in women, including the negative impact on adherence to treatment. In session 1, we will talk about what is SAVA and why is it important. SAVA is known as a syndemic. It is the intersection of substance abuse, intimate partner violence, and HIV, and we've added in depression. These are intersecting epidemics. We're going to talk about the prevalence of these problems in the general population, as well as in persons living with HIV, and their implications for HIV outcomes. So SAVA was conceptualized in the mid-90s as a set of closely intertwined and mutually enhancing epidemics fueled and sustained by social and economic inequities. Each of these problems contributes independently to the collective health burden on women, but they also act synergistically to negatively affect health outcomes. And this is what we mean when we talk about the SAVA syndemic. As I mentioned, we have added depression to the original components of SAVA. This slide and the next slide contain some definitions. I'm not going to go over these in detail. You'll be able to look at these at your leisure. But just to point out a couple of things. Intimate partner violence encompasses more than physical or sexual violence, but also emotional and psychological abuse and verbal abuse. Substance use disorders include both alcohol use and illicit drug use disorders. And opioid misuse includes both the use of illicit drugs such as heroin and the misuse of prescription pain relievers. Major depressive episodes are generally defined as over the last 12 months of 1 or more 2-week periods of feeling depressed, lost interest or pleasure in daily activities for most of the day, nearly every day, and problems with symptoms such as sleeping, eating, energy, or having recurrent thoughts of death or suicide. We know that mental illness and substance use are major problems for individuals in the US. This is data from SAMHSA, and it shows that in 2019, over 61 million Americans, men and women, had a serious mental illness and/or substance use disorders. This was an increase over the statistics for 2018, which was composed entirely of increases in mental illness. There is a lot of overlap between these problems. And you can see that among those with substance use disorders, this often was the most common substance use disorder was alcohol use. And 1 in 9 individuals struggled with both illicit drugs and alcohol. This just demonstrates the change over time in the drugs involved in US overdose deaths. And I think the main point here is looking at the dramatic increase with synthetic opioids such as fentanyl. This is looking at current binge and heavy alcohol use among individuals 12 years and older. This is 2019 data. And you can see in the whole universe of some 139 million alcohol users, 65.8 million were binge users. And of those, about a quarter or 16 million were heavy alcohol users. This is data also from SAMHSA looking at major depressive episodes over time from 2016 to 2019. And you can see that there has been significant increases, particularly though for those under the age of 50 over this time period. And in terms of violence, about 1 in 5 women report having experienced severe physical violence from an intimate partner in their lifetime, and about the same proportion have experienced sexual violence by an intimate partner. We know that adverse childhood experiences have a dramatic effect on adult life experiences and increase the risk of some of these problems, such as mental illness, substance abuse, and intimate partner violence. About 60% of people in the general population have had one or more experiences of abuse, neglect in childhood, or caregivers who have had substance abuse problems. And the risk for problems in adulthood increases significantly with larger numbers of adverse childhood experiences. This is in the general population, significant interrelationships between intimate partner violence, mental health, and substance abuse. And as we turn to consideration of HIV, it's important to note that these problems also increase the risk of HIV acquisition. And for substance abuse, we know that injection drug use accounts for 9 to 28% of transmission in women with newly diagnosed HIV, but I think we often don't think about the role of non-injection drug use, as well as alcohol, increasing the risk in HIV behaviors. So in 2019, about 7,000 women were newly diagnosed with HIV. 1 in 9 women with HIV, it is estimated, are not aware that they have HIV infection. Currently, women account for about 22% of adults and adolescents living with HIV. And when we look at the care pathway, about 3/4 of these women have received or are receiving HIV in care. A little less than 60% are retained in care, and 64% were virally suppressed at their most recent viral load test. It's also important to know that racial and ethnic minorities are more likely not to be diagnosed with HIV until late stages of disease. Heterosexual transmission is the major form of transmission of HIV among women. Injection drug use is more common in white women than in racial and ethnic minorities. This slide simply notes how important viral suppression is. Maximal and sustainable viral suppression prevent or delay the selection of drug resistance, preserves or improves immune function as measured by CD4 count, reduces HIV-associated morbidity, and prolongs life and the quality of life. And what has become increasingly important from a public health standpoint is the recognition that viral suppression prevents HIV transmission. Both HRSA and the CDC state that persons living with HIV or AIDS who take their meds daily as prescribed and who achieve and maintain an undetectable viral load have effectively no risk of sexually transmitting the virus to a partner without HIV. And that's what has been called U equals U, undetectable equals untransmissible. This is national data, again, looking from 2017 to 2019 and different demographic categories and viral suppression. And you can see, as we mentioned before, that women in the most recent statistics have viral suppression rates of 64%. And you can see that the rate among racial and ethnic minorities is lower than among white women, and it's lower among younger individuals than older individuals. Some of the reasons for these differences probably relate to the social determinants of health. We know, and it's increasingly important to factor this into our healthcare, the role that economic stability, that neighborhood or physical environment, education, food security, community and social context, and the healthcare system play in health outcomes. So when we look at these problems, intimate partner violence, substance abuse, and depression, now among HIV-infected women, we see that these problems are magnified. Women with HIV experience more frequent and more severe IPV than women without HIV. In a meta-analysis from a few years ago, 55.3% of women with HIV had experienced IPV, and that's over twice the national rate. We similarly know that rates of childhood physical and sexual abuse are over twice the national rate. We know that 40 to 50% of persons living with HIV in the US have a history of alcohol abuse or dependence, and about 10% of new HIV diagnoses are related to injection drug use. Depression is the most common psychiatric comorbidity among persons living with HIV, affecting about 30 to 40% of infected adults, which is over 3 times greater than in the general population. And women with HIV have twice or more the likelihood of being depressed than men. It's important to know that about half of patients who have depression go unrecognized, and about half of those who are recognized go untreated, all of which play a role in adverse health outcomes. This is looking specifically at physical violence and sexual violence among adults with HIV. You can see that lifetime physical violence by an intimate partner is experienced by about 25% of adults with HIV, and 17% have had forced sex in their lifetime. This is also from the meta-analysis looking at the high rates of traumatic events, including PTSD in women living with HIV. And if you look in the third column under prevalence, you can see really the dramatically high prevalence of all of these problems among women living with HIV. It's important to know that patients who have PTSD are 2 to 3 times more likely to have a substance use disorder. And this is looking at, again, the interrelationship of each of the SAVA variables with the other variables. So if you look at along the top line, it's the outcomes, and you can see, for instance, that poor mental health is 1.56 more likely in among patients who have a substance abuse problem. And you can see that with all of these outcomes. So why is this important besides simply providing the best care we can? In terms of HIV, the problem is that these conditions have an adverse effect on HIV outcomes. Depression in the setting of HIV is associated with reduced adherence to antiretroviral therapy, missed appointments, reduced levels of viral suppression, and ultimately higher rates of AIDS-related morbidity and mortality. Women with a history of violence are significantly less likely to have viral suppression. And several studies have shown an association between alcohol and illicit drug use and poor adherence and lack of viral suppression. And we will turn now to Q&A period.
All right. Thank you, Dr. Anderson, as always, for a great presentation. Well, that's one of the longer ones. We will have some shorter ones with Dr. Anderson and Allison, but we're going to have Lauren go through the key takeaways from that presentation.
The key takeaways for today are substance use disorders, intimate partner violence, depression are all common in the general population and even more common in settings of HIV and AIDS. These problems frequently occur together and work synergistically to increase the risk of HIV acquisition and increase the risk of adverse HIV outcomes in those with HIV. Only 64% of people living with HIV are virtually suppressed, but there are variation by race and ethnicity, age, and other characteristics. Social determinants of health play a major role in these differentials and also contribute to the risk for SAVA. And that's our key takeaways for today.
Thank you, Lauren. And before I just open it up to Q&A, I know some folks joined during that presentation, so welcome. We thank you so much for being here. If you don't mind putting your name and in the chat and where you're practicing and what you practice, that would be wonderful. And my colleague Amy might be reaching out to you. I know some folks are joining from tablets and phones, and your name might not be appearing, so she will be reaching out to you so we can get that fixed and make sure that we count you as attended. So I'll open it up for any questions that you might have seen during that presentation or any comments.
And while people are thinking of comments or questions, I just point out a couple of things. One is, if you notice that a lot of the data we presented ended at 2019, and there, one of the reasons is that this was prior to the COVID pandemic. So there was a lot of, which we'll talk a little bit about in one of the subsequent sessions, but a lot of interruptions in care. But I think probably most of you are aware that some of the problems we're talking about were really further magnified both in the general population and in the setting of HIV by COVID. So increases in violence, increases in substance use and overdoses and increases in depression and other mental health disorders. So that's one thing. The other thing is just to kind of drive home sort of the importance of viral suppression. There's a huge federal initiative now called EHE, Ending the HIV Epidemic. And that's because it's really felt that with the tools we have currently, we have effective treatment, we have effective means of prevention, that it really is a legitimate and that we are able to eliminate essentially HIV if we take advantage of these. But a lot of the problems we're talking about are still some of the real barriers to that, to getting people into care, keeping them in care, and keeping their virus suppressed. So I'd love to hear your thoughts, comments, experience, because as Rachel said, we learn from you as well as hopefully you learning from us.
We do have one question from Patricia in the chat. And again, for folks that join late, if you're unable to turn your camera on or come off mute, definitely put it in the chat and we'll read that aloud. Patricia said, does the incidence of IPV decrease once the partner's viral load is undetected?
Well, I think that it's probably the opposite, that if you can deal with the violence, that it's a greater likelihood of having viral load suppression. The evidence suggests that it's that trauma, if it's ongoing in particular, but also it's more likely if they have a history of trauma, that is a factor in them perhaps not accessing care, not taking their antiretrovirals as adherently as they need to.
Thanks, Jean. Thanks for the question, Patricia. Do you know what percentage increase in domestic violence we had during the COVID pandemic?
I don't know the answer to that, particularly in the HIV setting. Maybe Lauren or Allison know, because it's in both. It's in the general population, but I haven't seen any statistics. We could probably look up and try to find some data on that. But Lauren or Allison, do you have any ideas?
So in the community that I serve in which is an urban community in Pennsylvania, we've actually seen an increase in domestic violence, and that's just locally for us. So nationally, I don't know if that mirrors. That's something that I'd be happy to look up and then share next week with the group. But we did see, especially because the pandemic in our area had affected individuals who were maybe seeking shelter, and a lot of the shelters were full, and certain programs were only taking a certain number of participants. So individuals who are experiencing intimate partner violence were often left to go back to the person who was abusing them, or an unsafe situation for housing primarily. And again, that's just what we've experienced in our community here. I'm not sure what you saw in your area with your patient population. I don't know, Allison, if you saw anything similar.
Yeah, so I also don't have national numbers, but I know that we did see an increase, at least in our patient reporting, even though that didn't necessarily mean that they then were out of the situation. Also, a lot of the women I've worked closely with are pregnant, and pregnancy actually, as Dr. Anderson said, increases your risk for intimate partner violence. And I think, basically, all this, the whole situation we had in COVID was basically a crucible for everything to be enhanced. So all the issues that people had that contributed towards intimate partner violence were magnified. So we saw that. Somebody has a question. Then when we address the IPV with our clients, then we can hope for the viral load to decrease. Is there a specific intervention that is recommended? So I would just say, and I'm going to then have Dr. Anderson or Lauren or anybody else speak to this. What we've seen and is that, you know, if somebody is, in terms of disclosure of HIV status, a lot of patients that I work with do not want to disclose their status to their partner or anybody around them. And often they are afraid that there will be violence if they disclose. So they won't take their HIV medications because they don't want them around to be identified. So what we see is patients that are living in unstable situations tend to not be take their medication, and therefore they're not going to have as much viral suppression. Now, one of the things we try and work with our patients on is that, you know, how do you, if somebody is in a situation that's difficult, whether it's, you know, whether they're actively using a substance, whether it's they're depressed, whether there's intimate partner violence, is how do you work with somebody to still have them take their medication despite those circumstances? Because sometimes there's those circumstances, it's very difficult to make a change, but at least try and encourage viral suppression during those things.
And I think this is something we're going to talk about over the next few weeks, because it is the whole, we know that from the data that I presented, as well as other data, that these problems are highly prevalent. But the real question is, what can we do about them? And what we can do about them is it may vary to some degree where you are located and what resources you have, but we are going to talk about that a lot more. And I was just going to go back to the question of percentage increase. I think that, and I'm going to try to look up these numbers to have them maybe for our next session, but I think the data in terms of how much of an increase often comes from hotline data. It also comes from overdose deaths, suicide hotlines, different things that people have used to show that these things are increased.
Great questions. And I just want to mention, we also have a list of other resources on our website. And like I said, earlier, we also meet with a group on Tuesdays. So we always encourage that group, and we will with you. If there's anything you think would be beneficial to everyone that we can put on our website, just let us know and we will be sure to do that. So it'll be, if you want to check out the resources, it's on our website, and we'll give you the link for that later. Any other question? Jean, were you going to say anything
I was
else?
just looking at in the chat from Kathleen, Dr. Christoph. Thank you. She's in Philadelphia and serves inmates and has an interest in care of patients with substance abuse and HIV, and is interested in providing MAT, or medically assisted treatment. So definitely, as we talk about some of these interventions, would love to have your input and expertise in this.
Yeah. Any other questions before we move on to our case? And typically in the next few weeks, we'll have more time to discuss for the Q&A and for the case. This week, we spent a little time doing introductions and everything. And everyone will receive a copy of the slides. It's the presentation that Dr. Anderson gave. And for those that reached out in the chat that would like a copy of the intro slide, just on what ECHO is all about and what you can expect, we'll send those to you as well. And Lauren just put another link in the chat. Lauren, you sent directly to me, so you might want to just send it to the group.
That's fine. I can do that. I just wanted to make sure that would be okay. So
Oh, yeah.
that's fine. I did come across two good resources about the pandemic and the shadow effect, they're calling it, of the pandemic and domestic violence. So it looks like the nation in the United States averaged an 8% increase during the pandemic. So I'll send those two resources to everybody.
Thank you, Lauren. And Anita asked, how many sessions are we having? There's going to be 4 more sessions. It's the same time, so it's Thursdays at 12 Eastern. If you are unable to make it, though, we do record these sessions and we put them up on YouTube, so you can watch the video, and there will be a link to claim credit, which I didn't mention at the beginning. If you would like CME or CE or social work credit, that's something that you're seeking. Fill out the evaluation, and Amy will put a link to that in the chat at the end. You just have to make sure you're signed into your DKB Med account. If you're having any issues with that, reach out to us and we'll get that fixed for you. All right. No other questions? I think we'll move on to the case. Jean, are you presenting this one?
Allison's going to present this.
Okay, great. Allison, did you want to see the case form or go through some
I'll
notes
just go
first?
through a brief, just paragraph summary, and then we can look at
Sure.
the case form. I just wanted to say that when we present these cases, the idea is not that we have all the information, that, you know, we want to hear from people what your thoughts are, and if you have similar patients, what you would do. So in this particular situation, it's a 57-year-old African-American woman diagnosed with HIV in 2010. Her CD4 nadir was 194, most recent 620, and we'll have this sheet as well. Currently undetectable, but has had 2 detectable viral loads in the last year. One of 4,800, one of 900. She's on Odefsey. She has no history of resistance. She has a history of depression. Lexapro is on her med list. She's divorced. She does not currently have a partner. She has 2 adult children, and her son lives with her and has a current substance use disorder. So in terms of this general situation, if this woman came in presenting this information, what would you think about as important to know, and why would you consider it important? And we can also put up the sheet just to go over the specifics again.
Everyone, at the beginning, I mentioned that we've got this patient case form, and that's what this looks like. It is on our website. We would love to have one of you, one each week, present a case. So if that's something you'd like to do, let us know. We'll provide you with this form. We just ask that you share it with me ahead of time, so I could share it with Jean and Lauren and Allison so they can review it, and then we'll have you present it. So this is the case that Allison kind of just summarized. So we'll just go through some of the key points here.
So female, born in 1964, Black, African-American, cisgender, heterosexual. So she is not a new diagnosis, was diagnosed in 2010. She was 46 at diagnosis. So nadir, 194, a good CD4 now of 620, currently on antiretrovirals prescribed, a detectable viral load within the last year. So, and the highest was 4,800. She disclosed of her HIV status. She has not told anybody. She did have a friend she told about her HIV status, but has not told anybody else, and that friend died. We have concerns about adherence. She forgets when she drinks. She actively uses alcohol, some marijuana, depression. She had been previously engaged in care, history of childhood trauma, has asthma, hypertension, a previous ankle fracture. And if we keep scrolling down, she's had medications, Lexapro, lisinopril, Odefsey. Prescribed psychotropic was the Lexapro, and no MAT, not pregnant, 2 children, 1 living with her, which is the adult son who has a substance use disorder. She's separated, divorced, speaks English, housing is stable, She has access to a car. She's food secure. She has not been incarcerated in the last year. She's had 3 emergency room visits in the last year. She's missed 35% of her visits, no-showed. She has a positive IPV screen for the past. And her current screen, her substance use screen, I'll call is a 4. And her depression screen is a 16. Her ACE score was 7 out of 10, which is pretty high. So what are people's thoughts on this?
This is someone, I guess, who needs a lot of help. It's not the typical person, but really, she's on so many meds, and I really don't know what I would do to take her and switch. And I'm glad that there are people who do want to take care of people. That one person would occupy my whole day. I'm glad there are people who are really schooled in treating these patients, because I could not handle a patient like that. She would take up most of my day. I think the other things, you also get frustrated because there's so many things that are going wrong there, that the patient needs help from so many different sources at the same time, and compliance is going to be a big problem. So I would be at a loss, other than having her see an infectious disease specialist. I would not take on a patient like this for my own practice.
Well, I think that's a really great point, in that a patient with all this going on can be very time consuming. Screening is time consuming. That's one of the things we talk about. And then trying to find the resources. And if the patient also wants to engage in resources. Kathleen wrote poor social support, and Barbara wrote, I would want to know if there was a peer program available, and if so, utilize peer support. So we are strong believers in peer support as extremely important in helping patients. Dr. Anderson, looked like you had something to say.
I wanted to say to Paul, I think you hit on some really important things, and it's one of the challenges we face in even implementing a screening and referral program is time. And we're going to talk about some of those later, but this is a real patient, but it's a complex patient. And you also said something about needing to do a lot of things at the same time. And that's true too. This isn't a kind of where you do one thing and then you see what happens, and another thing. You really have to prioritize and try to be on several tracks at once. In terms of, we're going to talk a lot more, and we'll probably mention it every single session, but I think that Lauren and Allison and I are all very, very sold on the use of peers, sometimes called peer counselors, peer supports, peer navigators. But the concept that somebody who is perhaps from the same community, from the same group culturally, who maybe has either been living with HIV or has family or friends who are affected by HIV, has a different perspective often than those of us who are providers, and can really offer something. So let me, Allison, I think you had some comments.
Yeah, I just put in the chat because I know we're going to be out of time soon, but one of the things that we had to look at was why her viral load was elevated, which was actually related to her binge drinking. And so kind of having to address that with, treatment or some way to work around that. And then, of course, she's depressed. The drinking is going to increase her depression. But even though something's on somebody's med list, it's like, she actually was not taking her Lexapro. It was prescribed, but she wasn't taking it. But again, the person, Team Jones, said about the peer services, extremely important. And then, trauma exposure. She does have a history, high ACE score and a history of childhood trauma, which are all going to, mount up to impact her.
So all of these things, I think we're going to talk a lot more about. One important point is that if you just look a snapshot of where she is right now, it looks actually fairly good. Her viral load is suppressed, her CD4 count is high. So, and her med list is reasonable, but as Allison said, she's not taking her Lexapro. Her viral load has been high within the last year, so suggesting that she's not adherent to her antiretrovirals. So some of these can be clues that there is something going on that the patient may not disclose to you at first, and should be red flags to ask more questions.
Thank you. Thanks for everyone for your comments in the chat as well. Just in the interest of time, we're just going to go to that post-test. So I'm confident we'll get 100% on this. First question is approximately what percentage of women with HIV have experienced intimate partner violence? Is it 10, 30, 50, or 80%? And 2, injection drug use accounts for the highest proportion of HIV transmission among women from which group? And while you're answering that, Amy will put the link to claim credit in the chat. And again, as I mentioned, you'll receive an email with the slides as well as the link to claim credit. And if you would like to present a patient case, let us know. Okay. We'll just give everyone, all right. We're almost at the end of the hour, so let's end the poll now. And let's see. We're a little split, but most said 30%. What's the correct answer here, Dr. Anderson?
So the correct answer is 50%. It's actually 55%. I think it can be a little bit confusing. So I'd give partial credit to 30% because it's different studies, but the 55% comes from a meta-analysis looking, sort of combining a bunch of different studies.
Okay, question 2. I was hoping we would beat the Tuesday group, but we're split on this. So what's the correct answer here?
So the correct answer is white women. And I think the point is here that number one is that for some time now, heterosexual transmission has been by far the leading risk for HIV in the entire population. And this is true globally as well as in the US. Injection drug use, however, is still a real problem, and it is more common among white women with HIV in terms of their risk for having acquired HIV than among other racial or ethnic groups.
All right, thank you, Dr. Anderson. And I forgot to mention at the very beginning, we have a special echo clap at the end, since sometimes we're muted so we can't actually hear claps, we could see it. So I want to thank you so much for joining us. It's really great to see so many of your faces as well. And we'll see you next week at the same time. So 12 Eastern next Thursday. And any questions, feel free to reach out to us anytime. Take care, everyone. Bye.